Okay, we're going to talk about optic neuritis. And typically, optic neuritis is associated with multiple sclerosis. And usually, the symptoms it causes vision loss over hours to days, with the worst being 1 week after onset. And it could be subtle or profound. Usually, it's unilateral, rarely that it is bilateral. And the age is usually 18 to 45 years. And another symptom is pain. So we talked about vision loss. Let me redraw that eye. And also pain. And also color vision. That could be loss. And also perception of light could be decreased, as well as other focal neurological signs like weakness, numbness, tingling. There's also a previous flu-like viral syndrome that could have happened. There's also something called a pulfric phenomena, which is basically usually due to demyelination in one eye compared to the other eye. It's an optic neuritis, so it's related to the nerves, the optic nerve. The patient visualizes a 2D object as 3D. So let me explain that. For example, if I put a pendulum in front of a patient and I swing it like this, if I swing it from right to left, the patient would see this 2D action like this, it's going like this. No, he'll see it as going like this in a 3D way, which is not exactly what's happening. So this is a positive pulfric phenomena. There's also an Althoff sign, which is basically increase or worsening of the symptoms with exercise and heat. Now, recently, immune-mediated disorders of the CNS, like neuromyelitis optica spectrum disorder, they have been described as a cause of atypical optic neuritis. And atypical features would include advanced patient age, and severe vision loss, and with poor recovery, and simultaneous or rapidly sequential bilateral optic neuritis, so not unilateral. Now, we talked about the symptoms, let's talk about the signs. Critical signs include relative afferent pupillary defect, color vision loss, and visual field defects. Other signs like swollen disc, in 1/3 of the patients usually, without peripapillary hemorrhages. Papillitis is the most common disc abnormality seen in children and young adults. Sometimes a normal disc in 2/3 of the patient. Retrobulbar optic neuritis is more common in adults. You could also see posterior vitreous cells. Okay? So let's talk about the differentials. We have a lot of differentials that we should keep in mind. The first one being ischemic causes, ischemic optic neuropathy. So visual loss here is sudden, but in up to 35% of patients, it may progress over 4 weeks. There's no pain with ocular motility, but the pain can be with 10% of cases. When you compare that to optic neuritis, the pain with optic neuritis is 92%. Optic nerve swelling is due to non-arteritic ischemic optic neuropathy. That was a mouthful. It's initially hyperemic and then it becomes pale. And optic nerve swelling in giant cell arteritis is diffuse and chalk white. Patient tends to be older, and that's it for ischemic optic neuropathy. The other differential could be acute papilledema. Now, this is usually bilateral. It's not unilateral. And there is normal color vision, no decrease in visual acuity, no pain with ocular motility, and no vitreous cells. Another differential is severe hypertension. So obviously, this patient will come with what? With high blood pressure and other things that we see usually with hypertension, like flame-shaped retinal hemorrhages and cotton wool spots, as well as bilateral disc edema. Another differential is orbital tumor. So, orbital tumor compressing the optic nerve will be unilateral with proptosis, resistance to retropulsion, and restriction of extraocular motility. Another cause is intracranial mass. Now, an intracranial mass is usually compressing the afferent visual pathway. The patient will come with normal or pale disc, afferent pupillary defect, decreased color vision, and obviously a mass on CT or MRI. Another differential, which is Leber hereditary optic neuropathy. And this is usually in males in their 20s or 30s, and they have a family history. Patient comes with rapid visual loss in one eye and then the other eye. So early exams may reveal peripapillary telangiectasis, followed by optic neuropathy. Optic atrophy. So peripapillary telangiectasia, followed by optic atrophy. Now, the seventh differential is toxic or metabolic causes of optic neuropathy. This will be progressive, painless, bilateral visual loss, and it could be secondary to alcohol, malnutrition, and toxins such as ethambutol, chloroquine, isoniazid, as we know is an anti-TB medication, chloropropamide, heavy metals, and anemia. So we're done with our differential list. Now let's talk about the etiology. What could be causing this? Obviously, MS is frequently the optic neuritis is frequently the initial manifestation of MS. Another etiology is, as we mentioned, neuromyelitis optica spectrum disorder. It should be considered in all first-time optic neuritis patients. Childhood infections or vaccines like measles, mumps, chickenpox, viral infections like mono, varicella, encephalitis, contiguous inflammation of the meninges, orbits, or sinuses, granulomatous, inflammation infections like TB, syphilis, sarcoidosis, cryptococcus, etc., as well as idiopathic causes. This could be an idiopathic optic neuritis. Now, how do we work up the patient? Well, first we need the history. So what do we ask about the history? Based on what we listened here and what we heard, obviously, we should ask about the patient's age, rapid visual loss, previous episode, pain with eye movement, and intractable hiccups, nausea, vomiting, and severe itching are features strongly suggestive of neuromyelitis optica spectrum disorder. Now, we should also do an examination, of course, ophthalmic as well as neuro exam. Okay, so in ophthalmic exam, we need to see the pupils, the color vision, the vitreous cells that we mentioned. We do a dilated fundus exam, and we obviously pay attention to the optic nerve. Now, another thing that we should do in all cases of optic neuritis, we should do an MRI of the brain and orbits. And there's an MRI here, as you can see. There is enhancement of the right optic nerve right here, which is very clear. And in typical optic neuritis, there will be short segment of optic nerve that is involved. In contrary to neuromyelitis optica spectrum disorder, there will be longitudinally extensive nerve that is affected. So in neuromyelitis optica spectrum disorder, MRI of the spine should be done. Why? To see signs of transverse myelitis. Now, another thing in the workup that we should keep in mind in neuromyelitis optica spectrum disorder, that is a mouthful. We should do antibodies like aquaporin, which is basically aquaporin 4, which is positive in this spectrum disorder, as well as an myelin oligodendrocyte glycoprotein. These will be positive, so we should do them. Well, what else should we do in the workup? A blood pressure. We should check the blood pressure and do a visual field test using Humphrey. And also, we should do labs like CBC, ESR, the antibodies that we talked about, as well as ACE level, Lyme antibody, trypanoma specific assay, chest x ray, or CT. Now, for the treatment, we should do, it depends on the case, obviously. If it's typical optic neuritis and the patient's seen acutely with no prior history of MS or optic neuritis, we should offer a pulse IV steroid within 14 days. Okay? And how do we give this to the patient? Well, first we should give methylprednisolone 1 gram a day IV for 3 days. Then we give prednisone 1 milligram per kg per day PO for 11 days. Then we taper the prednisone over 4 days, giving it 20 milligram on day 1 and then 10 milligram on day 2 through 4. We should also give gastric prophylaxis like omeprazole. We should give that 20 mg PO daily, or ranitidine 150 mg PO BID. Now, there was an optic neuritis treatment trial, and it found that steroid treatment reduces the initial progression to clinically definite multiple sclerosis for 2 years. Steroid only increases the rapidity of visual return, but does not improve final visual outcome, sadly. Now, if an MRI shows 2 or more characteristic demyelinating lesions, we should treat the patient with the mentioned steroid and refer to a neurologist, because this is pointing towards an MS, or a neuro-ophthalmologist. And there are 14 drugs that are FDA approved for treatment of MS. Now, if a patient has 1 or more typical signals changes on MRI, this patient has a 72% chance of developing clinically definite multiple sclerosis. There's also something really important that I'm actually going to write down. You should never, ever use oral steroid as a primary treatment. Never, ever, because there's an increased risk of recurrence. Now, if there's a negative MRI, the risk of multiple sclerosis is low, 25% at 15 years. So observation used to be an acceptable option, but now we have NMOSD lingering as another differential that could be there. So you should have a high suspicion for this condition, and you should do pulse IV steroid in all patients, as well as additional serological studies for antibodies that we talked about. Now, if a patient is diagnosed with prior MS or typical optic neuritis, you can either observe or give pulse IV steroids. If it's an atypical optic neuritis, like NMOSD, which is the antibodies are positive, or even a seronegative disease. If it's an acute optic neuritis, you give high-dose IV steroids first, that we talked about this. But if the patient didn't respond, then you give plasmapheresis. Obviously, this patient needs long-term immunosuppression, so you should refer him to a neurologist or a neuroimmunologist. And actually, eculizumab was recently approved by the FDA for AQP4 positive neuromyelitis optica spectrum disorder. Now, that was a lot for the treatment, but now let's talk about the follow-up. If a patient has typical optic neuritis or MS, you should follow up 4 to 6 weeks, and then every 3 to 6 months. If there are no features of MS, you need to repeat the MRI every 6 months initially, and then annually to monitor for development of MS. If a patient is at high risk for MS, for example, there are CNS demyelination on MRI or a positive neuro exam, you should refer the patient to a neurologist or a neuro-ophthalmologist, because it should be managed of possible multiple sclerosis. You should keep it always in mind. Now, if we're dealing with an atypical optic neuritis, which is the patient has neuromyelitis optica spectrum disorder, even closer follow-up initially may be necessary because there are relapses and there's severity of vision loss. So we should follow up within 2 weeks of initial treatment, uh, and we should refer the patient rapidly to a neurologist experienced in treating neuromyelitis optica spectrum disorder. And that's it.